So today we will know how to interpret a blood gas, and I will skip some slides, but if you guys want to read it, it's up to you. But I will only concentrate on important issues. So you'll talk about definition, general tips, pH and the buffer, sampling and normal blood gas, acid-base status, reading blood gas slip, process, acute versus chronic problem, compensation versus non-compensation, and differential diagnosis. So pH means a free hydrogen concentration. And the result of the pH is inversely related to free hydrogen concentration. That's the pH. So it's inverse, or it's the root of the free hydrogen. Acid is a substance that can donate hydrogen, and when you give hydrogen, it makes the pH low, because as we said, the pH is the inverse of the hydrogen, and that's mean low pH, high hydrogen mean more acid. Baseline is a substance that can accept hydrogen ion, and therefore it raises the pH because it decreases the hydrogen, and we said that the pH is the inverse of the hydrogen. Anion is the ion with negative charge, while cation is ion with positive charge. Acidemia conventionally said when the pH 7.35, but that's actually not always correct, and we will talk about that at some point. Alkalemia, however, it's more than 77.35, and that's just a number. That does not mean anything clinically. So we have acidemia, we have alkalemia, but we have the acidosis. The acidosis is the process or the disease that cause high hydrogen or low pH. So it's a process or a disease that increase the acid or decrease the alkali. Alkalosis, on the other side, is also a process of disease that raise the pH due to decrease in acid or increase in bicarb. And something called actual bicarbonate value. And in the gas machine, it's reported as C, corrected bicarbonate value. You have to know that the bicarbonate is actually a derived value. It's a calculated value. It's not a measured one. And it's calculated from the pH and the PCO2 using Henderson-Hasselbalch equation. The biochemistry lab, on the other side, they do enzymatic assay, which is a direct measurement. So the bicarb that is measured by the lab is a measure, while the bicarb that is measured by the blood gas is a calculated one. Now, is that clear? Any question?
Yes, it's clear.
Yeah, and therefore, if there is a difference between the calculated and the measured bicarb, mean that the difference is coming from CO2 or the pH, not actual bicarb. So if there is, you have a chance that you have a lab value and you have a blood gas value, then, and usually if there is a difference, then the difference is due to change in the pH. And the PCO2, not actually the bicarb measurement, because as we said, the C bicarb is actually driven from CO2 and pH. There is something called indigenous source of acid. So the body can supply the acid. It's a daily production of about usually 1 milliequivalent of hydrogen ion for every kilo of the body weight during a day. Example, sulfuric acid or sulfuric containing amino acid, organic acid, intermediate products from metabolism, phosphoric acid from hydrolysis of the phosphate, hydrochloric acid from metabolism of cationic acid, amino acids such as lysine, arginine, and histidine. So it's multiple biochemicals, and you don't need to memorize it, that produce acid. So what is pH? pH normally regulated, or it's said that the normal value is 7.35 to 7.45. And you'll see that when we work together, that is actually not correct, because at the current standard of care, we don't consider normal value, but we consider acceptable value, permissible value, okay, compromise value, and so on. There are many names that we use to not consider a baby with, let's say, pH of 7.25 to be acidotic. And we have three types of buffer that trying to correct the pH. And the first one is a respiratory buffer, but we have also chemical buffer, and we have renal buffer. Buffer is a chemical system. It's either release or accept hydrogen ion to try to prevent the changes in the pH that usually resulted from acid or alkali. And it's a first line defender against changes in the pH. The buffer is either acid or base. The acid provide hydrogen ion, and the alkali or the base accept hydrogen. Example of the buffers we have, of the chemical buffer, we have the extracellular buffers such as carbonic acid anhydrase, phosphate, protein, ammonia. We have the intracellular buffers such as hemoglobin, intracellular protein, phosphate, and the Henderson-Hasselbalch equation is part of this process by combining the water with the CO2 to perform dihydronic acid, and then one bicarb. So this is the first line defender, is the chemical buffer, but also we have respiratory buffer, which is considered the second line defense against change in the pH. So about 10 to 12 millimole of CO2 can be generated in the body daily. It goes to the lung, attached to the hemoglobin, and at the same time generate bicarb. The respiratory buffer changes the pH and acid within minutes. And usually it's affected by some sort of balance in neuro-respiratory control. So the brain and the breathing control the pH. So what happened when we have acidosis, increased hydrogen ion, there is chemosensors that sense the decrease in pH. So as the pH decreases, it will stimulate the ventilation to wash more CO2. So the CO2 decrease. And then we move to phase 2, where the body try to hyperventilate to wash CO2. However, sometimes this CO2 wash can overwash and resulted in alkalosis. So it's very important to, when look at the baby with tachypnea, sometimes you get acidosis and sometimes you get alkalosis. Acidosis usually is the process, and then the respiratory system will be able to neutralize it, causing normal CO2 and maybe normal pH. And then sometimes it overcorrect and resulted in alkalosis by washing more CO2 and decreasing the CO2 in the blood. The renal buffer, it's non-volatile. It's not deal with gas. It's non-volatile alkali and gas. It add acid when we lose bicarbonate. The increase in acid as a buffer in the kidney by conserving result in the kidney that try to not filter the CO2 to correct the acidosis. Or it can form the bicarb. So either it bring back the bicarb from the urine or form a new bicarb to correct the acid. And this is the equation. I don't want you to memorize it, not important. So now we've talked about pH, PCO2, buffer, some sort of boring information. But now we will go to the clinical part. Now, I've considered the previous one because I just want you to be aware of it, but you don't need to memorize it. So how we take blood gas? We have arterial blood gas. We have venous blood gas, and we have capillary blood gas. When we say a reference value, we're talking about arterial blood. And remember, the arterial blood gas, we have a preductal and postductal. Preductal mean when the supply from the aorta and the heart before the duct connect the aorta to the pulmonary, and therefore it have a different result. So the arterial may be radial, maybe umbilical, maybe dorsalis pes, maybe posterior tibial, and even femoral. We have capillary blood gas, and you will observe when we work together that we need to arterialize the capillary blood gas by warming the area. So when we take blood from the heel to do capillary blood gas or CBG, we warm it up to do a process called arterialization, or making the capillary looks like the artery by heating or by warming the heel, for example. However, in the capillary, there is slight difference from reality, because remember, we say the reference is the arterial. So the pH will be slightly lower because the CO2 is a little bit higher. The PO2 in the capillary blood gas is of no value. Venous blood gas, however, we should never, ever, ever, ever ventilate based on venous blood gas. Remember that. You should never, ever, ever, ever ventilate based on venous blood gas because all the values are wrong. However, there is benefit of blood gas. There is benefit when we check the pH for poisoning, such as paracetamol or aspirin, but also we good for pH when we have dehydration or acidosis due to sepsis or diabetic ketoacidosis. All these are beneficial. That's one. So whenever we need a pH for eye, venous blood gas is a good option. The other options is we can find the oxygen and the CO2 of the artery and the venous at the same time. And we can by them estimate the ventilation by amount of CO2 washed, the difference between CO2 of artery and vein. Also, we can find the difference between the venous and the capillary, and we found the tissue oxygen extraction. Now, is type of blood sample clear or not? venous, arterial, and
Thank you,
capillary.
doctor. I just have a question. In the
Go ahead.
arterial blood gas, is there any difference
Okay.
in interpretation between taking sample in different arteries, for example,
Yes,
radial
as I said,
versus femoral?
yes. Yes. Now, there is difference between postductal and preductal. So in a newborn period, but after that, there is no difference because the duct, if the duct is open, mean you're mixing the
Mm.
non-oxygenated with oxygenated blood and making difference. So the branches of the arteries, the tributaries of the aorta that's taking the origin from the aorta before the duct will have a better values than those taking the blood from the aorta after the duct. So from right upper hand or maybe air lobules, the result will be different from the left upper hand or lower limb, such as umbilical artery or femoral artery or left side radial artery. The result will be a little bit different. Other arteries, if there is no PDA or there is no shunt, usually there is no difference.
Okay. So beyond the neonatal period makes no difference.
It makes no difference. And if there is a difference,
Okay, thank
it's tiny. Any other question?
Okay.
So you will see that we will talk when we work together that acceptable blood value. However, these values and this number that you see is just for research and for documentation. But in reality, you will see that we have permissible blood gas result and acceptable blood gas result rather than normal blood gas result. Well, the permissible or acceptable blood gas depending on the sickness level, depending on the gestational age, depending on postnatal age, and so on. There are many factors that sometimes we consider even if the blood gas number below the reference range that we have. But in general, the normal pH is 7.35 to 7.45, and the CO2 usually somewhere between 35 to 45. And the PO2 is a little bit wider range. And when we look at the gas and O2 in the blood gas, we measure not the gas attached to the hemoglobin, we measure the gas that is dissolved in the plasma. So please don't mix up between PaO2 and the saturation measured by the pulse oximetry. And these are normal values, normal reference values for pediatric term, for preterm babies and very preterm baby. And usually, as we said, we consider all the results or the numbers of the arterial gas. We consider the same capillary if we warm it, arterialize it, except oxygen. And we said also remember that the venous blood gas is of no value except some chemical disorders such as inborn errors, such as poisoning, we need to consider. You'll see two numbers. Some people write base excess, some people write base deficit. So base excess when the results are positive, base deficit when the results are negative. But some people write it base excess and write the number and then put minus. That's also correct. So we have base excess, base deficit, or base excess plus, base excess negative. Clear? Questions? Acid-base status, we have metabolic acidosis, and remember when we said it's the clinical process. When we have low pH, and the low pH is either due to high CO2 or low bicarb, but when we say metabolic, it's usually low bicarb. Metabolic alkalosis on the other side is increased pH by increasing bicarb. And remember, the pH is inversely proportional to the bicarb, to the PCO2, and it's parallel or in the same direction of bicarb. So remember, bicarb and pH one direction and the PCO2 in the other direction. So when you have a respiratory acidosis, by increasing PCO2, the pH will go down. When we have respiratory alkalosis, by decreasing PCO2, the pH will go up. So remember, PCO2 and pH on the other side, while bicarb and pH on the same side. So how we read a blood gas, how we interpret, what are the process, how we approach. First thing, before we document and comment on a current blood gas, we need to see the previous blood gas. It's very important to compare this result with the previous gas. The second is we need to ask how the sample was collected. And it's very important when you look at the blood gas, you look at the baby, you look at the monitor, you look at the graph, you look at the loops, and you look at the non-invasive result before you decide. And the other thing you need to consider is this artery, vein, or capillary. When we look at the arterial blood gas, the indwelling catheter is way important than arterial stab or intermittent punctures. So it's not advisable that whenever you need blood gas, you prick the artery and take the sample. The result won't be optimal. The best way is to put a catheter, arterial, and leave it there. So it's very important to consider the type of the sample when you comment, in addition to the previous result. So if we have these two answers, then we ask ourselves, is the child ventilated or not? Once the child is ventilated, what type of ventilation? When we look at the slip for blood gas, you will see that there is a temperature. This temperature should be the same temperature of the body. So for example, when we cool a patient and the temperature is 35, the machine temperature should be 35. If you keep the temperature of the machine the same, then you'll have a different result. And we have equations. If we cannot change some of the machines at temperature are fixed, we have equation how to correct a blood gas result because of the difference between the human body temperature and the machine temperature. Is that clear?
Doctor, so what shall we do if there is difference in the temperature?
Either you correct the temperature of the machine and make it the same temperature of the body, or there is equation that I will provide you to correct the result.
Okay.
The first few lines, is actually either the calculated and the measured value. Remember, we said that the bicarb, okay, is the calculated, but sometimes you find this actual. This is measured, not calculated. You can see this patient oxygen is 454, so he's very toxic. They are exposing him to much oxygen, and it's very dangerous situation. You can see that this child is also washing CO2. The CO2 is dropping, and you can see the pH is on alkalotic side. So mostly this patient have respiratory alkalosis and over ventilated. You can see the base excess, and they write it minus, so that means it's a base deficit, 1.3. The other group is co-oximetry or carbon monoxide oximetry. It measures the hemoglobin. It also measures the oxygen connected to the hemoglobin and give you methemoglobin, other type of hemoglobin in percentages. So you can see that the most hemoglobin are the hemoglobin attached to the oxygen, and there is a few attached to the carbon dioxide. But also we have methemoglobin, and later on we will be talking at some point about methemoglobinemia and how it happens, especially when we give inhaled nitric oxide. Okay, if we have H hemoglobin also here. So you can see this is co-oximetry. It gives different type of oxygen. Here, these measurement measure oxygen status, different type, relation of various type of oxygen. We don't need to know about this, but it also is give you values of oxygen. You can see this is corrected to the actual temperature of the baby. So you can see this patient is febrile, and they correct the result according to this temperature. And you see the difference. There is a little bit of difference between CO2 went a little bit higher, PO2 it went a little higher, and the oxygen content of the alveoli is a little bit different, and so on. Also, you can see some electrolytes here, sodium, potassium, calcium, and ionized calcium. Okay, now this is total calcium, but also we can see chloride. Now this, you don't need to look at it if the temperature is the same, the body and the machine temperature. Any question about the gas slip? Again, you can see here's the identification, the temperature, amount of oxygen, who did the blood test, and so on. And then you can have the other result. And each machine you will have different type of slip. However, the principles are same. So when we interpret the blood gas, we consider the clinical setting. Then we can consider the type of sample, ABG, CBG, or VBG. If we have a serum blood gas, we compare the gas electrolyte with the serum electrolyte. And if there's a reference, the machine of the blood gas analyzer need calibration. Look at the abnormal values. Consider is it respiratory due to CO2 or metabolic due to bicarb, and calculate an ion gap. We need to know the clinical scenario, the sampling itself, which place, and is it artery, vein, or capillary, how long it was taking, how transported, was hemoglobin, what is the room temperature, was it put in ice or not, and so on. And always we have to ask ourselves why we're doing the blood gas. Are we going to evaluate the ventilation that we're giving to the baby? Or we gave some intervention and we look, or we are doing it as a diagnostic test? Or we are monitoring the regression or the progression of the disease. You also need to consider other factors such as FiO2, hemoglobin, fluid, urine output, lactate, age, gas, loops, graphics, trend, and so on. And remember, in blood gas, in arterial, the pH and PCO2 are measured while the bicarb is calculated. Now, because the bicarb is calculated, if you measure it in the serum at the same time, the difference should be between the calculated and measured not more than 2 to 3. So, is there a problem? Yes, acidosis or alkalosis. Acidosis, either high CO2 or low bicarb. High CO2 respiratory, low bicarb metabolic. Alkalosis, either low CO2 or high bicarb. Low CO2 is respiratory, high bicarb is metabolic. Remember, bicarb and pH going always in the same direction, while pH and PCO2 are always in two directions. So when you see the reverse, then there is compensation. So if the bicarb separated from the pH, not on the same, that means a compensation process started. And if the pH and PCO2 became on same direction, then that means a compensation. Now, remember the bicarb is a metabolic process and PCO2 is a respiratory process. If you see everything on the same direction, then this is a correction process or compensation process. And the compensation, I don't want to go to details. I don't think it's important. It's respiratory or alkalosis, and it's chronic and acute. You can pause and read this slide. I don't want to confuse you with this information right now. We can also know it's a chronic or acute, but I will not speak at this moment. We'll speak in future. Remember, respiratory compensation is very fast and metabolic compensation is a little bit slow. Compensation, it can give you full compensation, it can give you partial compensation, and give you no compensation. If you see overcorrection, because compensation will never do overcorrection, that means the patient acidosis, it should be normalized. If it becomes alkalosis, then you have two problems at the same time, or mixed disorder, overshoot. This means that the overshoot is not due to the correction, it's due to correction and other disorder. Anion gap, it depends whether you're considering potassium or not. I don't want to go into details because, again, I don't want to confuse you, because this is not the time of anion gap. Different cause, CAT mobiles of increased anion gap. I also don't want to consider this right now. Mixed disorder mean respiratory and metabolic, depending on the bicarb and the PCO2, and also depend on the clinical history. We have a map called the Flenley nomogram that help us to distinguish between acute and chronic disorder. And this is the Flenley acid base. So if you select the arterial PCO2 and the pH, and you draw a line in between this line and this line, when they meet, it will tell you what is the problem. It's not necessary. There is the delta ratio, and there is the HAGMA and NAGMA, very important. The delta ratio is the change of anion gap over the change of CO2, which is also equal anion gap minus 12 or 24 minus bicarb. And if it's less than 4, it's hyperchloremic non-ion gap metabolic acidosis. The HAGMA and NAGMA may be isolated renal failure. And HAGMA is high anion gap metabolic acidosis. And NAGMA is non-ionic gap metabolic acidosis. So not very important, but I just want you to know that it's existing, the delta gap. You can also pause the slide and read about it. So summary, it's either respiratory or metabolic, either acidosis or alkalosis, and it's either uncompensated or partially compensated or fully compensated, and there is example of it. Normal newborn blood gas, as we talked, these are starting, but also we have what we call acceptable or compromise changes that we see it less or higher than these numbers, and we accepted it as normal depending on the situation. Now, I also don't want you to go in details of this. I just want you to know, but there are many causes of differential diagnosis of metabolic acidosis. So I want to pass all these. And I want to stop here. Hopefully, next we'll take initiation, maintenance, and then weaning from the ventilation. And also, hopefully, that we can start ventilating mannequins in the next week when you start working with me. And I'm gonna postpone the high frequency and the intrapulmonary medication because I want to speak about other topics such as IV fluid, TPN, and nutrition. And also, I want to speak about management of airway. So I'm going to postpone 2 sessions, which is intrapulmonary medication and high frequency, to catch with other topic because I hope that we can start working soon. Any question?